So 27 million Americans with, with osteoarthritis. By far, most of the joint replacements in the world are done for osteoarthritis, right? And in this country, last year, there were about 500,000 hip replacements done in 1 year. About 700,000 knee replacements done in 1 year. That's just in this country. So that just goes to show how common these things are. And it's getting more common. You know, when you look at the predictions for knee replacement, especially, the predictions for knee replacement are that by 2030, we'll probably be doing 1.2 million knee replacements a year in this country. It's in part because the population is aging, right? But that's not the only thing. It's also because folks are remaining more active, right? And are less likely to put up with the pain of arthritic joint in the years that they want to remain active. Where generations past, when folks became painful because of their arthritic disease, they gave up and slowed down. So it's interesting to see those statistics. So what I'm going to talk about tonight a little bit is about some of the new developments in hip and knee replacement. You know, because both of these operations have been around now for about 5 decades. And so they keep getting better and better. And some of the changes are small and some are pretty profound. And then we'll have some questions. We'll have plenty of time for questions at the end. So bear with it. We'll talk a little bit about hip replacement first. Hip replacement, I want to talk about a procedure that some of you might have heard about called anterior hip surgery, right? And in knee replacements, I'm going to talk a little bit about what we call a custom fit knee replacement. How many folks in this room have a joint replacement? So yeah, right? Maybe a third of the room. So this, you'll see, things are probably very similar to what you went through and maybe changed a little bit. So this is, when we talk about the hip, right? Like Lisa said, this is a ball and socket, right? And the ball is covered with that white shiny cartilage, and so is the inside of the socket. And that's what deteriorates with osteoarthritis. So a hip replacement is a matter of replacing the ball and socket with a combination of metal and plastic. If you looked at an arthritic hip, you'd see that the ball has this white shiny cartilage that is in tatters and is thin, right? And same with the inside of the cup. So when we do a hip replacement, we have to get down below the muscles like we talked about. We remove the ball, okay? And then we put a metal cup on the inside, then a plastic cup inside the metal cup, and then a metal stem, and then a ball. That's it. It's so simple, right? Easy, right? Everybody who's had one can say, oh, it's a piece of cake. Anybody can do that, anybody can have one, but that's what a hip replacement is. And this is what's been around for a while. So it's essentially a few parts. It's a metallic stem that fits into the thigh bone with a ball on top of it, a metallic cup that sits into the pelvis with plastic inside. So that's a hip replacement. And you say, well, you know, what's all this about anterior hip surgery? What does that mean? And why is that a big topic? Why do we see that in the paper? And why does everyone want to get it done with the anterior? Well, you got to think, okay, what does anterior and posterior mean? Anterior means the front, right? And posterior the back. The idea is still the same. Either way we do it, we still have to get that combination of metal and plastic into the bone, right? So the bone is kind of in the middle. So if the bone is in the middle, what's the big deal on whether you go in through the front of the hip or the back of the hip? Well, it has to do with how the muscles are arranged. Now, I wanted you guys to spend some time memorizing this slide because we're going to talk about it at the end, all right? We'll start from number 1 and go down. The reason for this slide is just to show you the anatomy is different in the front of the hip and the back of the hip, okay? This is the back, right? This is the posterior, right? So those are the gluteus muscles. And you can see that in the back, the muscles move in this direction. That's even at the first layer. Then if you go down in a deeper layer, the muscles still move in that side-to-side way, right? Okay. In the front, it's different. In the front, the muscles move in an up and down way, okay? And when muscles end up at a bone, they end up at a tendon that attaches to the bone, right? So if you can imagine, the hip joint is underneath here. And the only way to get to it is to remove some of these tendons from the bone, actually separate the muscles from the bone, and get down into the joint. Where this one, the hip joint is in here. And so to get to it, there is a way to spread those muscles apart. So that is really the difference. So when we do hip surgery from the front, we can spread the muscles apart and enter into the hip joint. This is the hip joint underneath. Now this is nothing new. You know, when you look at this, you know, we have these cartoons here, but what we're showing is, that showed the posterior, everybody knows what that is, the back, and the anterior is in the front. So the incision is just below the waistline in the thigh, in the lateral, in the side of the thigh, right? The muscles are spread apart, and there's the hip joint right there, okay? And then, so very simply, we just kind of slide in the ball and socket. Even easier now,
Yeah,
right? So you say, well, you know, is this something new, right? Is this way to get into the hip joint? Could that really be new? And the answer is no. That a long time ago, and some of you might remember that, you know, tuberculosis was a bad problem for a long time, right? And one of the places that tuberculosis went was into the hip joint. Getting some feedback. So a long time ago, surgeons figured out how to drain tuberculosis out of the hip. And how did they do it? In the 1940s, they did it this way. They separated the muscles because they said, oh, all the muscles in the hip go up and down, so if we want to get into the hip joint, let's just separate them. So hip replacement, so hip surgery from the front was common in the 40s and 50s, right? And so then some of the pioneers in joint replacement surgery said, well, if this is how we know how to operate on the hip, and we're having this new technology of replacing body parts, why not put the hip joint in through the front, right? And so that's how it was done. The original hip replacements were done by spreading the muscles in the front and getting the hip joint in. So why is this suddenly something new? You know, all this time later, 70 years later, why is it such a big deal? Well, what happened was those early hip replacements, right? They were kind of small and rudimentary, and they were very easy to get in through the front because they were small, right? But the problem was they didn't stick to the bone, and they failed, and they didn't work, right? The technology didn't work. Even though the surgeons knew how to put it in through the front, the technology didn't work, and so the failure rate was very high. So what happened as technology advanced, in 1962, John Charnley in England came up with the idea that the reason why hip replacements are failing is because they're not attaching to the bone. And so he came up with this stainless steel implant that was very long, much, much longer than those other implants that you saw, right? And this worked, right? But the problem was this implant was too big to put in from the front. Just the way we had to move, they had to move the legs to get it in, it was too big to put in. So he figured out a way to put it in from the back and the side. The only way to get it in from the back and the side was to separate the tendons and muscles. To actually separate them, put this in, and then reattach them, either with sutures or wires. And it worked, right? And it worked. And the implant lasted, and it lasted. This was called the low friction arthroplasty, and it lasted, and it was a breakthrough. So everybody said, well, that's the way to do it. The problem is, when you separate those muscles and tendons and ligaments, they take a long time to heal. So even though this implant worked and it lasted for years, the recovery was a long time, right? Because you had to let all those tendons and ligaments heal. So posterior hip surgery became very common because the technology advanced to this size. This is a stainless steel type implant. So through the years, materials have changed, right? Our understanding of the anatomy has changed, the different sizes of implants we've needed. And then so the materials have also changed from stainless steel to cobalt chrome to a new super alloy that can be made much smaller and still be as strong or stronger than stainless steel, and that's titanium. So here we are now in 2014, all the hip replacements we put in pretty much are made out of titanium. And because they're made out of titanium, we can make them smaller again. And they're smaller and they stick to the bone, they last, right? And so then folks said, well, if these are smaller implants, why not put them in through the front again like we tried the first time in the 1950s? And so that's where we are now. So this brand new technique of anterior hip surgery is actually redoing what somebody figured out a long time ago, but the technology has changed. The implant technology has changed, and also the technology we use in the operating room has changed. This is what the modern operating table looks like, right? I'm talking about this is the latest operating room table for hip replacement surgery. This is what we call the HANA table, right? And you say, I know what you're saying. He just said, oh, you know, the reinvention of the anterior approach was something that was designed a long time ago. And some of you are saying this looks pretty familiar too. And anybody who's been to London, the Tower of London, has seen the rack, right? And that's what it looks like. So it's a reinvention of the rack. And the idea is that when somebody is on that table, just like the rack, you can strap their legs into it and you can move the hip around. You can separate the joint. You can do things with it that you can't do in the operating room if you just have you and your assistants. But you can crank this rack a little bit and move things open, and it's a holder. It's a giant holder, right? So this is what the invention is that has propelled hip replacement surgery, anterior hip surgery in the operating room to a different level. So when we look at these things, you know, this is a holder that lets us get into the hip joint and move the ball and socket around and still have access through that same interval that does not cut the muscles and tendons. So anterior hip surgery, the advantage is, you know, using the new technology of titanium and smaller implants and a reinvention of the rack, which is the fancy schmancy OR table that we use now that can pull the leg apart, we have a faster recovery, right? Compared to what I was doing 15 years ago or even 6 years ago, folks recover much faster. Walk the same day as the operation, stay in the hospital for 2 days, right? Less weakness, because when we spread the muscles apart to put the implant in, instead of taking the tendons apart, the muscles are much stronger right from the beginning. And also, there's no restrictions. Many of you in this room who have had a hip replacement were given a list of things you were not allowed to do, because if you did them, something bad was going to happen. And the reason you got that list of hip restrictions or hip precautions was because the muscles were too weak to hold the ball and socket together until it healed. But now that we don't have to separate the muscles and tendons, folks don't have any restrictions. So they can do what they want right away. So the advantage of anterior hip surgery is that people get moving faster and they have no restrictions. And the whole idea of joint replacement surgery is to maintain health. So this is not to get people out of the hospital faster, but to get them off their back so they don't get other problems that are related to laying around the hospital for a long time. So anterior hip surgery is something new that uses a lot of old ideas with the new technology. What about knee replacement? Knee replacement has also been around for many years, 40 years, 50 years really. They say, well, what's knee replacement? A knee replacement, like a hip replacement, is treating the ends of the bones, right? And the knee joint, like the hip joint, has got a white shiny cartilage at the end of the thigh bone, a white shiny cartilage on the top of the shin bone. And so what happens with osteoarthritis is those cartilage parts deteriorate and they become worn out. And so they wear out completely at some point till they're completely gone, till it's bone right on bone. So a knee replacement is a matter of replacing the worn out cartilage with a metal cap on the end of the thigh bone. Okay, this is a metal cap on the end of the thigh bone. This is the thigh bone. A metal cap on the top of the shin bone. This is the shin bone. And then in between these two pieces of metal is a piece of plastic. So the surgery is to change the shape of the ends of the bones to put these metal caps on. So the first thing we do is change the shape of the thigh bone, and then put a metal cap on the end of the thigh bone, change the shape of the top of the shin bone, put a metal cap on that, and then a piece of plastic in between. And that's a knee replacement. Again, how simple can it be, right? That's easy. Anybody can do that. So this is the concept. This has been around for a long time. You say, well, how much better can you make that? I mean, that's, well, we can make it better by saying, look, people who come in for these joint replacements have all different shapes of legs, right? These machines, the mechanics of a joint replacement, this combination of metal and plastic works best when these parts are perfectly aligned, right? And so you take something that is not perfectly aligned and you want to change it to something that's perfectly aligned. So over the past 40 years, we've had instruments that we've used in the operating room to do this. The instruments look a lot like what you'd find in a carpentry shop. Protractors, dial gauges, calipers, right? Yeah. And they work, right? Because we have to change this to something that's straight in line. So what's happened in the past decade is saying, okay, well, all these instruments are nice and they do the job, but how could they be better? So about 10 years ago, we started using computer-assisted surgery, right? Which, like a GPS in your car, we had an operating room computer system that would shine down, and anything that was within this range, we could see in 3 dimensions on the computer. So if we wanted to dial in a little bit of extra counterclockwise rotation, if we wanted to dial in 3 degrees, we could look at it on the screen and do it in real time on the computer to get the alignment as best we could. It increased the precision of the operation. Didn't necessarily change what we were doing, and that is getting the bones to get metal caps on the end, but it would improve the precision that we did the operation. And we know that the more precise the operation, the better the knee functions and the longer it lasts. So we did that for many years. Now we're into the next level of computer-assisted surgery, and that is to say, well, if we can realign, if we need to realign the bones, why not do it on a virtual image to start with, right? So this is what's called the custom fit knee replacement. The way it works is we get a CT scan. A CT scan is a 3-dimensional X-ray, right? And we get a CT scan of the whole leg from the hip to the ankle. And in particular, look at the knee. So we can see the knee in 3 dimensions on a computer screen. And if you can see something in 3 dimensions on a computer screen, you can operate it on the computer screen. So we do the whole operation on the computer. So we have a virtual model of the knee, of the patient's knee, from a CT scan, and all those measurements that we need, we can make on the computer. We can try things out. We can try different sizes. We can say this alignment is good or this alignment doesn't work, right? And once we're satisfied with the way the operation is done on a pretend knee, your pretend knee, then we can send that information to a company that makes instruments that fit exactly on your knee, not on anybody else's knee. And these instruments have built into them all the necessarily alignments, right? So this is what's called custom fit. The implants, the metal caps are the same, but the instruments that we use to put them on there are made from this. So this is it. You see all these things that spin around? This is the way it works. That's the custom fit instrument. Goes onto the end of the thigh bone. The custom fit instrument goes onto the top of the shin bone. It's disposable, right? And then the implants that come in are the same. The metal cap on the end of the thigh bone, the metal cap on the top of the shin bone, and the piece of plastic in between. So the end result is the same, the knee replacement, but the custom fit instruments allow us to do the whole operation on the computer first. And so that way, when we're in the operating room, We're no longer scratching our heads saying, well, you know, is this a size 4 or a size 3? Well, let's try the size 4, and if that doesn't work, we'll change it to a size 3, or, oh, we need to cut a little bit more here, or we need to change it. We've already done that. We've already done the big thinking while I'm at my desk having a cup of coffee, and you guys are at dinner, hopefully having a glass of wine. And so nobody's under anesthesia, and the surgeons have no stress because they're at their office, right? So we'll do the whole operation, all the big thinking on the computer, and then execute the plan in the operating room, which means the operating room is more efficient. If the operating room is more efficient, it means less anesthesia. Less anesthesia means less impact on the body, and it seems to be a faster recovery and a more precise operation. So that's what a custom fit knee replacement is. The final thing I wanted to talk to you about was the way with both the anterior hip approach and these custom fit knees is how we treat the whole experience of coming into the hospital and going home. In particular, how do we control pain? This is what we call a rapid recovery program. The idea is to minimize the amount of toxic drugs, like morphine, that people get, right? In the old days when we would operate, and then the patient would make it to the recovery room, and we'd just hope for the best. And when they had a lot of pain, we'd flood the system with a lot of pain medicine. And as you know, these pain medicines are really detrimental to someone's ability to think, walk, act, and eat. So we try to minimize the amount of heavy-duty pain medicines that we use by using this kind of a program which we call rapid recovery, where before the operation, folks get some pills, right, that operate. They're pain pills that work by different pain pathways. During the operation, we inject the local tissues with an anesthetic, right, which is like Novocaine, so that when folks wake up, they're not in a tremendous amount of pain. And finally, after surgery, we put folks on scheduled pain medicine, so we don't wait for the pain to get bad before someone asks for the pain medicine. In this way, we can get folks to walk on the same day as the operation, almost always. They also have no restriction, wear nice clothes, you know, don't have to wear those hospital gowns because we have no IVs or catheters or hoses, so people can wear their own clothes and really get home. And folks go home instead of going to another institution, from a hospital to another institution. Almost everybody goes home. At least 87% of people go home within 2 days after the operation. So this, you know, when I first started doing this operation, folks would stay in the hospital for 10 days. And for those first 4 or 5 days, they were laying on their back with tubes and catheters and drugs coming in. Now, all the tubes and catheters are gone. Folks walk the same day as the operation, certainly the next day, go home in a couple days, and then have the visiting nurses and therapists come to the house to initiate the rehabilitation. Thank you very much.